Hi, my name is Brittany Richwine, and I will be talking about clinical prediction rules. So what are clinical prediction rules? Clinical prediction rules, abbreviated as CPRs, are a set of simple tests or observations specific to a given disease or illness used to help determine whether the patient has a specific disease or illness. They're designed to help clinicians and patients make decisions, and they're also referred to as prediction rules, probability assessments, prediction models, decision rules, and risk scores. How do CPRs work? Each predictor is assigned a weight. Each predictor must come back either positive or negative for the given issue. Depending on the outcome of the predictor, the patient is given a cumulative score, which determines the risk that the patient is at for the given issue. The predictors are identified by a process called data mining, which is a process of selecting, exploring, and modeling large amounts of data in order to discover unknown patterns or relationships. And then predictors should be highly sensitive as well as specific. So basically this is just saying that they should be able to identify the highest proportion possible of patients fated to have the outcome, which is the sensitivity, as well as excluding those who will not have the outcome, which would be specificity. Analyzing the results. So visually these are represented by using a curve with the sensitivity on the x-axis and the specificity on the y-axis. Phases of establishing clinical prediction rules. So there are 4 of these. The first being development, which is just identifying them from an observational study. Second would be validation, testing the rule in a separate population to see if it remains reliable. The third would be impact analysis, the usefulness, and then finally the implementation, which is just the widespread acceptance and adoption of this practice. So there are pros and cons. Some of the pros would be that CPRs are shown to be more consistent given the same data. They can account for greater numbers of factors. Many have been shown to be more accurate than clinical judgment alone. They also save expense and time for the patient. Some of the cons would be that they are not always user-friendly. They do not take into account dynamic ways that humans gather information. Many CPRs have been made for the same issue, so this causes a problem of potential extra time being used up in figuring out which CPR to use for that given situation. So there are 5 different types of prediction models. The first is a scoring system derived from univariate analysis. So significant factors are weighted, and then the final cumulative score is used to predict the patient's likelihood of the outcome occurring. Prediction models based on multivariate analysis, which would be similar to the above but more refined, so they are less likely to include any non-independent factors. Nomograms, which would be a graphical calculating device that is very simple at times or can be very intricate, but it is usually very accurate. There are official neural networks, which are mathematical or computational models based on the operation of biological neural networks. Basically, information is put into a software program, it is interpreted, and then an output key is produced. These are very accurate, but they're hard to use at bedside and do require more computer technologies than some of the other methods. And then finally, the 5th is a decision-making tree. This would be a classification and regression tree, which uses non-parametric tests to evaluate data and divides these into subgroups, which are easily understood, but may be less accurate than some of the other models. CPR and athletic training. So CPRs are very useful as far as athletic training goes because it's very typical for ATs to stray away from non-musculoskeletal issues, but using CPRs may make it a little bit easier and a little bit lower anxiety to identify these possible causes of the non-musculoskeletal issues, as well as musculoskeletal issues as well. And this would help them to quicker identify the issue, which would result in a quicker recovery for the athlete. It's also a lot more cost effective for the athlete or say the school that they may be working at or whatever corporation that would be. For this example, I have a CPR here for 2-year mortality and early diffuse cutaneous systemic sclerosis. So as you can see, there are 4 different characteristics used. So there's age at the first visit, skin thickness progression rate, GI severity, and then anemia. And then on the far right hand column there are points assigned. So depending on For example, if the age was less than 35 years at the first visit, the score would be a -1. So at the end of this, all of the points are combined, and then if the points are 0 or equal to, or greater or equal to 0, then they are at a low risk. If they are 1 to 2, they're at a moderate risk. Or if they are greater than or equal to 3, they're at a high risk. So to conclude the findings that I had from this study, if you examine the p-value in the previous chart, all of the 4 predictors have a p-value less than 0.05. So that means with a 95% confidence, we can conclude that these predictors are indeed accurate in assessing the likelihood of mortality in early diffuse cutaneous systemic sclerosis. So it also included that the area under the curve was greater than 0.05, or 0.5, excuse me, which means that the area under the curve is greater than 50%. This means that the results would be accurate. They would cover greater than 50% of the cases. So generally we accept clinical prediction rules as long as the area under the curve is greater than 50%. It said that the findings were not significant for low or moderate risk levels, but they were much more significant at the higher risk levels. So they would be more effective in these types of settings. And then finally, I have some works cited. And that is all I have. So thank you for listening, and I hope that this was informational.